Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling something known as Guillain-Barré Syndrome. As always, let's kick it off with our practice question to get things started. A nurse is caring for a client diagnosed with Guillain-Barré Syndrome who was admitted 12 hours ago. He has progressive bilateral leg weakness. He is alert and oriented with symmetric weakness in both legs and areflexia. Which of the following assessment findings requires the most immediate intervention by the nurse? We have A, reports of pins and needles sensation in the hands and feet. B, heart rate of 104 and BP of 150/88. C, a decrease in vital capacity from 18 mils per kg to 12 over the past 4 hours. Or D, reports of severe aching pain in the thighs, rating this an 8 out of 10. Think through your answer, what's the most immediate priority, and we will circle back to it at the end of the episode. But first, of course, let's talk about what is actually going on inside the body so we can understand Guillain-Barré Syndrome and kind of get those priorities set in place. Guillain-Barré Syndrome is going to come down to the nerves. So we need to understand what our nerves are doing and all that jazz. First, I want to talk about the peripheral nerves, and I want you to picture them like electrical cables kind of running from the spinal cord all the way out to your muscles and skin. Side note, if you haven't listened to our episode on spinal cord injuries, it was 2 episodes ago, episode 99. That would be a really great place to start because we really talk about that spinal cord and what it does. Fast forward to today, we're looking at the peripheral nerves. Those are cables kind of running out of that spinal cord and again, going all the way to your muscles and skin. Inside of those cables, those peripheral nerves, we have bundles of axons. These are long projections that carry signals. And around those axons is something called a myelin sheath, which honestly you can just think of as the insulation to the cable. Myelin is made of Schwann cells in the peripheral nervous system, and its job is to help electrical impulses travel quickly and efficiently down the nerve. So instead of a slow, leaky signal, myelin allows for what we call, it's something called saltatory conduction, which honestly, I don't care if you remember that term or not. I just want you to remember that the myelin helps insulate the nerve so those signals can go down the axons nice and smooth and get to where they need to go. So for example, we've got a healthy nervous system, hopefully, and the brain's like, oh, I want to move my foot, I want to walk. It sends that electrical signal down the spinal cord to a peripheral nerve, through a myelinated axon, into the neuromuscular junction, and then finally to the muscle where the muscle contracts. And that's happening for walking, breathing, swallowing. I mean, literally everything. And at the same time, so that was our descending tract where we're sending out those signals. But simultaneously, we have our sensory nerves, our ascending tracts, sending up information to the brain. Touch, temp, pain, proprioception. I touched this, it's hot. Oh my gosh, tell my brain it's hot. Now it's going to send a signal down, pull your hand away. It happens that fast. And it can't happen that fast if we don't have our myelin sheath insulating the nerves and allowing those signals to move rapidly. Now in Guillain-Barré, that myelin sheath is going to be damaged. How it gets damaged is through our immune system. So a little recap here. Under normal circumstances, we know our immune system can tell self from not self with little ID tags that we've got on our cell surfaces. In Guillain-Barré, that ID system, that recognition of self, not self, that goes sideways. Typically, there is some sort of triggering event. Most commonly, you'll see a viral illness referred to. But it can be other things too. It could be a GI infection. It could be a surgery, a vaccination. We don't always know why, but most common one you're going to see is that viral illness. So we get a viral illness, the immune system ramps up, it goes and fights that, but some of the antibodies accidentally cross-react with components of the myelin, and then the immune system, it just gets a little funky. It gets overexcited, and it starts tagging the myelin, that insulation on our peripheral nerves, as if it was the enemy. Which means then those antibodies and immune cells are attaching to the myelin, destroying it, and stripping it away. This is what we call the most common form of Guillain-Barré, inflammatory, demyelinating polyneuropathy. All right, so acute, it comes on quickly. Inflammatory, the immune system is driving it. Demyelinating, we are damaging the myelin, that insulation. Polyneuropathy, it's affecting multiple peripheral nerves, neuropathy. So it happens fast, we get inflammation, body attacks the myelin, and when the myelin's damaged, that conduction is gonna slow down, or worst case, stop altogether. That electrical jumping across nodes becomes more like slogging through mud, and in some fibers, the signal is never going to reach the muscle at all. So basically, when push comes to shove, the motor nerves lose their ability to tell the muscles what they need to do. That's why we're going to see weakness and then eventually paralysis. Sensory nerves are misfiring, so when we have those sensations going up our afferent tracts, clients aren't feeling what they need to feel. That comes across as numbness, tingling, burning, pins and needles, or maybe they just totally lose sensation. All right, now this happens in a very specific order, and this is going to be one of your key buzzwords or features that makes you go, oh my gosh, this is Guillain-Barré. And that is the term ascending paralysis. So we don't just randomly start to lose sensation in a hand and then a foot and then over here. It always goes from the toes and feet and moves upwards. The reason for this, and I don't even really care if you get into the nitty-gritty too much, but overall, to help you understand, is that Guillain-Barré is quote-unquote length dependent, so the longer nerves are affected first. Well, what nerves are farthest away from our spinal cord? Down in our feet. So, that electrical cable, that's much longer, running all the way from the spine to the toes. It's the most vulnerable. It's affected first. And then as we come up, those nerves are shorter and shorter because they're closer to the spinal cord. So they are going to be affected last. So what matters the most for you to remember is that keyword ascending paralysis. It starts in the toes and it moves up, which should make you very nervous because as this keeps climbing, we are getting closer and closer to a very important nerve, the phrenic nerve. The phrenic nerve innervates or powers the diaphragm and the intercostal muscles. And what do those do? Those keep us breathing. If our immune system starts stripping the myelin away from those fibers, the muscles we use to breathe become weak. The brain starts screaming, breathe more, breathe faster, breathe deeper. But the signal doesn't get through. And we go from, I'm weak and tingly, pins and needles, to I can't move my chest, so I literally cannot ventilate. And this happens in a matter of at most dramatic hours. It can be days, but rather quickly. So if we zoom out real quick, big anatomical picture of Guillain-Barré here. Peripheral nerves are the wiring. Myelin is the insulation. Immune system goes haywire and it starts attacking the myelin, that insulation, after a trigger. We stop getting signals traveling very well without that insulation, and that starts with the longest nerves, so down in the feet and toes, and moves upward. Our symptoms are ascending. They start in the feet, then they go up. And as more and more get involved, we gradually lose voluntary movement, normal sensation, stable autonomic function, and most dangerously, when it starts to reach that phrenic nerve, the power of breathing. That is kind of the tipping point to when, we've got someone stable on a neuro floor and now we're sending them over to the ICU to get on a ventilator. So that being said, let's take that framework, let's put it into a case study and walk through a story together so you can think about what you would do as the nurse. We're going to be on a step-down neuro unit today, and we are admitting a 32-year-old man from the ED. He is usually healthy, doesn't have a significant past medical history. He has worked as a mail carrier and is coming in because his quote, my legs just aren't working right. He says about a week earlier, he had a stomach bug, fever, cramping, diarrhea, but it got better, no biggie. And 2 days after that, he started feeling tingling in his toes. He describes it like they had fallen asleep. He ignored that, shrugged it off as most of us would, but the tingling started to creep up to his calves, and he was having trouble climbing the stairs because of it. That morning, he actually stumbled and tripped, and that is what prompted him to come into the ED because he thought, okay, this is not getting better and feels dangerous at this time. So in the ED, the nurse does her assessment, and he is fully alert. He's conversational. Cranial nerve exam is fine, but his motor exam was not. Strength in the upper extremities is good, but the lower extremities are weaker. Remember, we grade that muscle strength out of 5. So uppers, 5 out of 5. Lowers, he got a 3 out of 5 at the hips and knees, and a 2 out of 5 at the ankles. So it's worse down in the feet. 2 out of 5, really not good, very weak, but not as bad up at top. His grip strength, he's shrugging his shoulders, those muscles are still 5 out of 5. The next bit of assessment you want to make sure to do is check our reflexes. Deep tendon reflexes, or DTRs, are going to go down when we have Guillain-Barré because we're not conducting those signals. And that is what we see in this client. So at the knees and ankles, patellar kick, Achilles response, we are not seeing a reflex. That's called areflexia, no reflex. So this is the classic clinical picture of Guillain-Barré. We had some sort of illness, that was the trigger. Boom, a couple of days later, we're starting to feel that pins and needles tingling. It starts in the feet, gradually getting worse, and it is ascending. I also want to note that it is symmetric. That is another keyword that you might see on your exams. It is symmetric and it is ascending. So his feet are really weak. We're lacking those lower reflexes. Uppers are not so bad. What do we do next from here? Okay, our nurse in the ED did a great assessment, painted a really good picture. Now it's time to get some diagnostics. So the neurology team's going to come in at this point, and very likely they are going to do an LP or a lumbar puncture. We want to rule out infection and see if there's anything funky going on in there. They might do something fancy with like nerve conduction studies. The neurologists are going to try to rule out other causes. This is not going to be something that we have like a simple image or one specific lab that we can say like, oh, yep, you're positive for Guillain-Barré. We're going to have to exclude other things, pull it away, and make that diagnosis based on the clinical picture. So neuro team working him up, they're getting him up to floor. He finally gets to us at the step down unit. We are nurses on the step down unit today. What's our focus at this point? We have a presumptive diagnosis of Guillain-Barré. The picture makes sense. Clinically, it's lining up. The neurology team's doing their workup. What do we focus on? I've kind of got two big things going through my head. Monitoring his progression of symptoms and staying ahead of that life-threatening complication of not being able to breathe, right? So I want very close monitoring of where that sensation and where that motor function is at. So if he stops being able to move his toes and then can't bend at his knees and then he can't feel at his hips anymore, right? We're getting closer and closer to the diaphragm. My whole picture is like, how close is this to the diaphragm? Because that's when we can't, in the step down unit, take care of that. That's when we need to go over to the ICU. So priority, lots of words to just say, respiratory monitoring. And one of the big things we're going to look at is something called vital capacity. Oftentimes, the respiratory therapist is also going to help us too. They might look at like negative inspiratory force, kind of measuring how much air the client can pull in and push out. But I think vital capacity is a great indicator because that basically just tells us how much air is getting in the lungs. It is by definition the greatest volume of air that we can expel or exhale from the lungs after we take the biggest, deepest breath possible. So how much air fits in there? And if that's going down, 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 we are not headed in a good direction. That means that diaphragm's getting worn out and it's not keeping up. So let's say vital capacity is at, and it's measured in milliliters per kilogram. So how many milliliters of air per kilo of body weight? So for this case study, we are going to say he is starting out at a 35 mLs per kilo of vital capacity. Normal, which I don't expect you to memorize, honestly, don't waste your time. Normal is usually cited as 45 to 75. I've also seen 50 to 65. Generally, you're going to see a little higher for males, a little lower for females, just based on anatomy here. So with him measuring at a 35, we are definitely below what we would expect as average, but it's okay. I'm really more worried about the trend. I want to know what direction that is heading. Over the next hours, your priorities in this neuro step down unit are to keep reassessing that progress, that ascending paralysis, and that respiratory status. So let's say that tingling starts to spread into the fingertips. Arms start to feel heavy. You reassess that vital capacity. Now it's down to 20, and he's taking more frequent, shallow breaths. That might be happening even though the pulse oximetry still looks okay. But it's moving in the wrong direction. So really, think about the anatomy. The numbers aren't just dropping. What you're seeing is that the immune system is attacking the nerves that are powering the respiratory muscles. They are slowly disconnecting the brain's ability to send that breathe command to the diaphragm and intercostals. So you're keeping a close eye on this as your priority. You notice it going the wrong direction. And your priority action is to notify the provider. We always say, if there's anything you can do for the client, do it. And in this case, we need the provider at the bedside to potentially intubate and escalate care to the ICU. So you are going to notify that provider. And in our case study here, within an hour, he is transferred over to the ICU and intubated. That is going to really help us kind of keep this client stable while we take care of the underlying process. Okay. So that's your first part of managing Guillain-Barré. Monitor. Look at that ascending paralysis, look at that vital capacity, that respiratory effort. But underlying this, what are we gonna do? We have two different therapies that we can try because what we wanna do is address the fact the immune system is attacking our myelin. We've gotta kind of get rid of that. So we have immunologic therapies. The first one, and I have almost always seen this one in practice, is called IV immunoglobulin, IVIG. It is like flooding the system with good antibodies that hopefully can help us neutralize those harmful ones and modulate the immune response. I have to admit to you, administering IVIG is one of my least favorite things to do as a bedside nurse because we make changes about every 15 minutes. So you pretty much have to stay right at the bedside, doing vitals, watching for a reaction, measuring things like urine output, and documenting changes. So these are great one-to-one patients, but if you are doubled or tripled, managing IVIG gets to be really hectic. So that's why it's like not one of my favorite meds. but it does really good things for Guillain-Barré because it gets in there and it helps kind of modulate that response so we stop destroying that myelin. Now, the other immunologic therapy is plasmapheresis, which is kind of like a blood filter, which tries to get out the bad antibodies and replace it with a clean fluid, that plasma. I have not seen that done for Guillain-Barré, but I didn't work at a center that treated a ton of it, so it could be more common in other areas. The key thing to remember, though, is that whether it's IVIG or plasmapheresis, these treatments are aimed at stopping the immune attack on myelin so the nerves can start to recover. Fundamental issue here is our immune system is attacking the myelin. So that's why we're prioritizing getting these treatments going. The other intervention that I'll lastly mention is that you do have to manage pain. We think about Guillain-Barré with causing weakness, but it can be incredibly painful to those damaged sensory nerves. People describe it as like burning, squeezing, stinging. I've heard people use the phrase like an electric pain, like a shock. So commonly I see a combo of opioids, neuropathic pain medications like gabapentin, and then we also, don't forget, have a lot of great nursing interventions and non-pharma strategies like repositioning, relaxation, dimming the lights. We want to kind of enter that parasympathetic rest mode and help them relax. Now, the good news is that most of these clients are going to totally recover. That underlying axon that the myelin is surrounding as the insulation often remains intact, and myelin can regenerate over time. So in our case study here, our client had to be intubated. He spent 2 weeks in the ICU. The disease process plateaued, so we stopped attacking that myelin once we administered IVIG or plasmapheresis. And with that plateau, he's not getting any weaker. So now we rest, we let that myelin regenerate, and it's almost like you've put a movie in reverse because that strength starts returning, and now it comes from the top down. So we'll first get strength back in his hands and his breathing and his core, and then down his legs. And we'll be able to wean that ventilator, transfer back down to step down, usually then to rehab. And they do usually go on to make a full recovery, again, because that axon is intact and the myelin can grow back. So all that being said, that brings us through the entirety of the case and back to our practice question. Hopefully now you can get to the right answer and understand why. We have a nurse caring for a client diagnosed with Guillain-Barré. He came in 12 hours ago with progressive bilateral leg weakness. He's alert and oriented, symmetric weakness in both legs, and areflexia. Sounds a lot like our client. Which assessment finding requires the most immediate intervention by the nurse? We have A, reports of pins and needles in the feet and hands, B, a heart rate of 104 and a BP of 150 over 88, C, a decrease in vital capacity from 18 to 12 over the last 4 hours, or D, reports of severe aching pain in the thighs, rated 8 out of 10. All right, think it through, shout it out, jot it down, say it to yourself, whatever. Hopefully you picked C. That decrease in vital capacity is what we are laser focused on because it tells us about our respiratory status. Now, I want to use a couple test taking strategies here on A and D. We've got, altered sensation and we've got pain. One of our test taking strategies is that pain never killed anyone. All right, I'm not saying it's not important. I'm not a mean nurse. I will absolutely give you pain meds. But when I'm prioritizing on the NCLEX, very rarely am I going to choose pain because it just doesn't kill people. Stopping your breathing, having your vital capacity go down, will kill ya. So I'm going to prioritize C over either A or D. And lastly, B, that heart rate of 104 and that BP that is elevated, that reflects autonomic involvement. I'm not saying that's good. Those changes are important. They should be monitored, but it's not as acutely dangerous as a change in respiratory status. That is your key takeaway to this Guillain-Barré episode. Guillain-Barré is an acute, inflammatory, demyelinating disease. We have some sort of trigger, and our immune system goes to town on that myelin. It starts stripping away the insulation from that nerves, causing bilateral ascending paralysis, okay? That is the key buzzword I want to make sure you walk away with. Because of that, your priority is their respiratory status. Watch how they breathe, their effort, their vital capacity, and how it trends over time. If and when it starts to go downhill, your priority is to notify that provider so we can escalate care and protect their ability to breathe. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.